Friends, a recent article in this JCRS June edition 2025 actually gives us the basic concepts, helps us to understand the basic concepts of astigmatism here. And in this edition of my YouTube video, I would like to actually take you briefly through the explanations that has been given on astigmatism. So, for those who are actually beginners, what is astigmatism? Astigmatism is the opposite of a spherical surface, right? If you have a sphere, say for example, whose power in all the meridians are the same, the curvature is the same in all the meridians, say in the vertical meridian as well as in the horizontal meridian, the curvature is the same. So rays of light that passes through these meridians, they actually fall at one point, and that is called stigmatic, right? But in astigmatism, what happens, the curvature in the vertical meridian and in the horizontal meridian are different. Therefore, when rays of light passes through the vertical meridian, they fall at one point, and when rays of light passes through this horizontal meridian, they fall in another point over here. So there are two focal points that are created now, and the distance between these two focal points is actually called the Strom's interval, or the Strom's conoid, or often called this conoid of the Strom, right? So the patient's vision drops. Why? Because you do not have one single focal point. You do not have a stigmatic, right? You have actually have an astigmatic. That is, you do not have just one single focal point. You have now two focal points over here. So if that is clear, then let us move on over here. It is also said that most of our astigmatism is actually regular. So you actually correct regular astigmatism with toric IOLs here. But sometimes the patients may also have some amount of irregular astigmatism. But for most patients, the irregular astigmatism is less. It is the irregular astigmatism which actually creates the deterioration in vision, and that is important, and that is why toric IOLs are actually provided to the patient, are implanted in a patient so as to correct the regular astigmatism. However, if in a patient the astigmatism is because of an irregularity of vision, then irregularity of astigmatism, then toric IOLs will not actually help, because toric IOLs only help in regular astigmatism. Now, coming back over here, I mean, if you get an astigmatism prescription, you might see it like this: plus 2 diopters, plus 2, plus 1.5, plus 1.5, and then it will give you an axis over here, and it will give you an axis. So what it means over here is that the plus 2 here is actually the spherical power. The 1.5 is your cylinder. So the spherical power is basically plus 2, which means that the patient has hyperopia. Hyperopia means what? The rays of light actually goes beyond the retina. And 1.5 is actually the cylinder. The cylinder means what? As I said before, here the rays of light passing through this 90-degree, and this rays of light passing through this 180-degree, there is a difference, and that difference is actually denoted by this cylinder, which is 1.5 diopters. And at what meridian do you have to place the glass to correct the patient's cylinder or astigmatism? Is at 90 degrees. So that is how actually it is represented, and that is actually the explanation that has been given over here. Now, coming to measurement of the keratometry reading, most of our machines, the biometry machines, do not actually measure the total corneal power. That is, they don't measure the posterior corneal power and the anterior corneal power separately and give you a total corneal power. If they had measured that, most topography machines may do that. For example, the pentacam actually will measure the total corneal power by, employing the correct refractive index of the cornea. The correct refractive index of the cornea is 1.376. So they have to use that correct refractive index of the cornea if they're measuring the anterior and the posterior corneal power, and then giving you a total corneal power. But our biometry machines, most of the biometry machines do not measure a total corneal power. They only measure the anterior corneal power, and then they give you the total corneal power. How do they give you a total corneal power? By only measuring the anterior cornea. That is by through a fictitious refractive index. So that refractive index, the fictitious refractive index of 1.3375, which is not the real refractive index, this is actually used in order to give you the total corneal power by a little bit of cheating. They only measure the anterior corneal power, but gives you a total corneal power for the patient by cheating a little bit by employing the 1.3375 keratometry refractive index, rather than using the 1.376, which is the corneal true refractive index, right? So that is something that has to be borne in mind. Now, what is the incidence of astigmatism? The incidence of astigmatism is around 39% of the patients in one study by Hoffer, actually. They found that 39% of patients had more than one diopter of astigmatism. In another study, in a large UK study of patients, 40% of the patients also had more than one diopter of astigmatism. So largely in other studies also in India, China and Brazil, it has been similar, the incidence of astigmatism has been reported. Among the cataract patients, now this is basically for all patients, but among the cataract surgery patients, what has been reported is that 30% to 35% of the patients have around with the rule astigmatism, 40% to 45% have around against the rule astigmatism. That's what actually has been reported. Now, this is a very important concept over here. There is a drift of astigmatism from the with the rule to the against the rule, right? And that drift, by most studies, they point out that there is usually a drift of 0.25 diopters to zero point 0.4 diopters per decade, right? So for older patients than 50 years, a mean ATR drift of 0.25 to zero point 0.4 diopter per decade has been reported. This is something which is important that to be mind. So some doctors actually like to keep a little bit of residual astigmatism on the vertical meridian so that they can compensate for the drift, subsequent drift. Now this is important over here. The cornea is actually prolate in shape, right? What do we mean by prolate in shape? That the cornea is something like this. So as you go to the center, the cornea is more steeper, and as you go to the periphery of the cornea is much more flatter here, right? So steeper over here and flatter here. Now, consider this: the if you had measured the keratometry with the manual keratometer that measures around 3.2 millimeters of the cornea, compared to the IOL Master, which measures around 2.5 millimeters. Say IOL Master 500 measures 2.5 millimeter of the cornea. So you're moving from 3.2 towards the 2.5 millimeters of the cornea. What do you expect the corneal reading to happen? The corneal reading will become much more steeper, right? From measuring 3.2 to 2.5, if you move to 2.5 millimeters, then for a normal prolate cornea, you will get a steeper value, because as you move towards the corneal vortex, you get more steeper values because of the prolate shape of the cornea. Now, this has been explained over here, and the a constant adjustment that you do while you move from the manual keratometry to optical biometry is because of one of these factors, is because you are now measuring a steeper cornea, because you are moving towards the corneal vortex. For a normal prolate cornea, you will get a steeper cornea for the same patient compared to a manual keratometry. Now, next, what is important to discuss over here is the concept of the dry eyes. Now, it has been seen in many studies that dry eyes can significantly actually affect the magnitude and meridian of astigmatism. And, it has been seen in this case, 76% of the eyes actually had an altered magnitude and meridian of astigmatism for those patients who had dry eyes. So dry eyes can significantly affect the toric outcomes. That is important to remember. So we need to treat the dry eyes before the toric IOL has been planned, because much of that astigmatism that you're saying could be because of the dry eyes. And when you treat the dry eyes, you might realize that there was no astigmatism at all. So be careful that dry eye is not causing the astigmatism that you're trying to correct with the toric IOLs, because that in that way the patient is not going to benefit. The other point over here is that sometimes the doctors actually instill artificial tears in the patient's eyes and then do the biometry, which is supposed not to be done, because once you instill the artificial tears, that alters the K readings, and once you alter the K readings, you can have a wrong IOL power that actually may not lead to a very healthy outcome for the patient. That is important to remember. The other thing that I'd like to bring your attention to is the concept of posterior corneal astigmatism. We know that JCRS 2011, Douglas Koch published a study which showed that if you are not taking into account posterior corneal astigmatism, either measuring it or theoretically accounting for it with the toric calculators, many calculators today take into account the posterior toric corneal astigmatism. So if you're not taking care of it, you are actually undercorrecting against the rule astigmatism and overcorrecting with the rule astigmatism. So overcorrecting with the rule astigmatism and undercorrecting against the rule astigmatism. Why? Because most studies shows that using a shame-flux imaging technology, it has been shown that mean posterior corneal astigmatism is approximately zero point 0.5 diopters in corneas that have with the rule astigmatism anteriorly, and zero point 0.3 diopters in corneas that have against the rule astigmatism anteriorly. And it is because of this you often tend to undercorrect against the rule astigmatism and overcorrect with the rule astigmatism if you're not taking care of the posterior corneal astigmatism. Next, I would like to draw your attention to the concept of lens tilt, and this is important because sometimes you implant a toric IOL and you don't know why there has been a significant amount of residual astigmatism, and that could be because of the lens tilt. Now, lens tilt, either pre-operatively before the cataract surgery, the patient might have a subluxated bag. Now, that could also create some amount of residual astigmatism post-operatively, or the toric IOL may have tilted post-operatively, and that could also create some amount of residual astigmatism. Now, this part actually I have covered in one of my articles in my blog quickguide.org, and there I have actually talked about how the lens tilt can actually significantly affect your refractive outcomes post toric implantation. So, in one of the studies, they have shown actually that when the lens tilted, when the IOS tilted more than 10 degrees, the resultant astigmatism increased significantly to zero point 0.4 to zero point 0.5 diopters. And some amount of study has been done by Wakert and co-authors on this IOL tilt and its impact on astigmatism. Now, before I go to the last part, which is the influencing factors for the subjective refraction. So you have implanted now the toric IOL, and you are, your optometrist is actually checking the eye, uh, checking for the magnitude of astigmatism that has been corrected. I would like to draw your attention to one of the articles that I have written actually in quickguide.org. Now, in this article, which actually gives you an understanding of how to check what went wrong in case of a refractive surprise. In that article, I have pointed out, two studies that has been done by Olson in 1992, and then a Norby study has been done in 2008. Now, Olson did the study in 1992 about the factors that influenced, the biometry, refractive surprise, and they found out that axial length in 1992 was the most important factor that actually influenced refractive outcome, and most of the refractive outcomes was actually because of the wrong axial length calculation. But Steve Norby, when he did the same study in 2008, this is a time, remember, of optical biometry, and he found out that it is not the axial length but the post-operative ELP which is the most important factor for the refractive surprise post-operatively. Now, they also found out that it was also a large part of the refractive surprise was because of determination of post-op refraction, meaning that your optometrist may have actually did not actually did a good job in actually understanding the post-op refraction of the patient. Now, having understood that, what are the influencing factors that could actually lead to a wrong refraction? That is the ocular surface post-operatively. Remember, cataract surgery itself may lead to dry eyes, so that is important that you have to check that the patient does not have a dry eye. Cyclopegia itself has an effect on the astigmatism axis. Pupil size also has an effect on the astigmatism. These are some of the factors actually that could actually uncorrected, as I was saying, lens still can actually lead to coma, and that could also lead to some amount of residual astigmatism. And these are some of the things that we need to actually keep in mind when we are doing a post-operative refraction. I shared this article because I thought that this is important. It is a very comprehensive article, giving a fundamental understanding about astigmatism. And for more understanding, you could actually visit my website. You can type astigmatism and Toric IOLs in the search button, and you'll find the articles that gives you, in depth, some of the concepts that we have talked today. Thank you very much for your patient listening.